Okay, good evening, everyone. Today we are into the 89th webinar of the Clinical Pulse, which is the unique PG track program by Delhi branch of CSI. And today we have with us one of the eminent teachers, or I might say one of the best we have around in India right now, teacher for DM and DNB, Dr. N. Sudhay Kumar, who is Professor and HOD, Travancore Medical College, Kollam. And with me, I have Dr. Sumod, who is my colleague at JVP Hospital, and Dr. Nitish Nayak from All India Institute of Medical Sciences. And without wasting much time, I would invite Dr. Sudhay Kumar to delve on his lecture.
Thank you for the nice words. Can I share my slides, or this has to be moved out? Yeah. Is it okay? Can you slay the slides?
Yes, sir.
Okay. Good evening to everybody. This time we are taking a simple thing, that is pulse and jugular venous pulse, starting from second year onwards. Even from the first year during physiology, you start learning this. You learn this for your examination, then you discard it. Then when it comes to the postgraduate for the examination, you take it again discard it. Following your DNB or DNB, you take it again and discard it forever. That is a usual thing which I have been saying. Okay. Is the slide moving?
Not really, sir. It is stuck at the introduction first slide.
Oh, what about this? Stuck?
Yes, sir. It's still at the same place.
Then
so please put it in presentation mode, so it will go there.
It is in the presentation mode now. Stop sharing. Last time also had the same problem, but share screen. PowerPoint. Let me take this. Is the second? Is it moving now?
Yes, sir. Now it's very well moving, sir. Yeah.
Okay, fine. Now you may be wondering why I have taken this topic, or why our faculty has taken this topic. It is for the benefit of the postgraduates. So obviously it is exam oriented. So there are two aspects of this thing. Number one, you are having training for 3 years. For practicing cardiology, I think it requires only 2 months. If you practice under a good cardiologist like Dr. Girish, Dr. And his team, Sumod, Dr. Mohit, I think it requires only 2 months. If you give me an MBBS student for 2 months, a good MBBS student, I can train him to manage practical cardiology. But that's not academics or postgraduate training or a cardiologist. The knowledge and concepts, that is the most important thing as far as I am concerned, especially teachers like us, versus practice, which is being done nowadays after your post-graduation. Majority of them go for intervention, electrophysiology or something. Very few may go for clinical practice. And I don't know how many of them will go for academic teaching and other methods of real cardiology. So that comes as a doctor versus cardiologist. Now, this is just a introduction. Now, information. What we get in pulse and JVP, rhythm status. Many times we have landed up problems in a white QRS tachycardia in the ECG to know whether it is SVT or VT. Many times it has been sorted out by clinical simple examination like pulse, JVP, and auscultation, the first sound. Okay, in tachyarrhythmia, it is extremely useful because all of us know tachyarrhythmia, regular or irregular. Irregular, it is atrial deletion. If it is a regular rhythm, then a varying pulse volume, a varying S1, and irregular canon waves indicate it is VT. It is almost diagnostic. Then you get hemodynamic data from the pulse and JVP, the cardiac output, the vascular resistance, the ventricular function, both right and left. And you get a lot of anatomical informations from the JVP as well as the pulse among various lesions you get. So it is diagnostic, therapeutic in the sense diagnosis and management, assess the response to treatment, and prognostic information also from all these things. So don't think that this simple physical finding, which many times we neglect, or we don't give too much significance in your so-called in your busy practice. Oh, I don't know what is that busy practice. Now, this is one thing which the postgraduate should know. Anybody who goes for cardiology should know this thing. That's why I put this slide. I don't have much time to discuss all those things, but this is a basic fundamental thing which nobody can escape. If I am the examiner, I ask a question on this. If the candidate doesn't make a good answer, I may not be very happy. I may not fail him, but I may not be very happy. Now, you should know the electrocardiogram, the venous pulse, the auscultative finding when S4 occurs, S1 occurs, S2 occurs, then the pressure tracing, simultaneous pressure tracings of all those things. The atrial pressure tracing, the right atrial, left atrial pressure tracing, the right ventricular, left ventricular, aortic pressure tracing. So this you should know. Now, today we had a discussion how the blood flows in the aorta. I just asked a question to postgraduates, ask them to write down the answer. The right ventricle during systole empties the blood into the pulmonary artery. How the blood flows throughout the cardiac cycle to the left ventricle. And you know that the flow to the left ventricle is in diastole. How the blood is flowing. Okay. This is a question. The students who are listening may just write down the answer in 10 seconds so that I will just hold on. How the blood emptied from the right ventricle in systole flows throughout diastole to the left heart. Okay. We are not seeing your answer, but self-assessment. This I am sure majority of the postgraduate may not know this mechanism. Other is I will tell you what else, what is the other thing. Now here, ventricular systole distends the aorta, and that produces the kinetic energy which is stored in the aortic wall. And once the systole is over, the distension is over, the kinetic aspect is over, the energy which has been relieved will be released, which has been stored will be released during diastole's kinetic energy, which propels the blood to the periphery. That is one of the main mechanisms by which it flows. But when it flows, there should not be any resistance to flow. And that is the answer to the simple answer. In ventricular, this is a process, but in ventricular diastole, the ventricle relaxes. So it draws the blood also. So there are two things. One, the kinetic energy which has been stored in the aortic wall during the distension is released during diastole as again kinetic energy which propels the blood in diastole. Then the ventricle relaxes, it accepts or draws the blood also. Okay, now coming to the pulse, you may know many things through qualium, all those things, but this is an important thing which I'm not sure how many of the postgraduates or the students know this thing. What you are recording, the pink one or the red one or the orange one is the pressure generated by systole. This is the dP by dt which pushes the blood, raises the pressure in the aorta because of that. And when it faces an obstruction like bifurcations or the arterial tone exerted by the arterioles. So when this high velocity flow or the distension goes and faces resistance from the arterioles, resistant vessels, it will be reflected back in the latter part of the systole as the reflected pressure. The green one is the reflected pressure. You get the summated pressure. This is the early systolic pressure and this is the late systolic pressure. And what you are recording as the pulse is this dark line. And what you are recording is also that. So this is the P1 or the systolic pressure, early systolic pressure. And this one, this part is the late systolic pressure or recoiling pressure. And this is the augmentation pressure. That is, during systole, it generates a pressure which is augmented by the reflection. And that is augmentation pressure. So from the peak systolic pressure to the diastolic pressure is the pulse pressure. And from the early systolic pressure, which corresponds to the anacrotic notch, if you can see, to the peak is the augmentation pressure. And the ratio is the augmentation index, central augmentation index. So that is it. Central augmentation index is the augmentation pressure, which is from the anacrotic pulse to the peak, or the early systolic pressure to the late systolic pressure. So this is the augmentation pressure. divided by the pulse pressure, the total pressure, that is the central augmentation index. The peripheral augmentation index is the ratio of the late systolic pressure to the early systolic pressure. This is the early systolic pressure, P1. This is the P2. P1 by P2 is the peripheral augmentation index, whereas P2, that is augmentation pressure divided by the pulse pressure, is the central augmentation index. This will be determined by the dP by dt, which determines the initial rise, and the reflection by the systemic vascular resistance. So this is importance in the arterial system. The arterial performance modifies this thing. So the ratio of this has an influence on or is determined by the vascular system, and it may not have prognostic implications in vascular diseases, especially atherosclerotic diseases. The stiffness increases, this index or this pressure goes up, the index goes up. There is no absolute values for this. You have to do in various groups and see what is the normal, what is in the diseased or the trial group. So the pulse, the basic simple things, the volume is determined by stroke volume, which in turn determines the pulse pressure. And another important thing is the rate of pressure rise, how it rises. If the rate of pressure rise is, because what you are feeling is this thrust. If the rate of pressure rise is fast, if it is high, the same volume pulse may be felt as a high volume. Then the stroke volume, which determines the pulse pressure. Stroke volume determines the systolic pressure, and the diastolic pressure is determined by the systemic vascular resistance. This is the normal pulse, where you have the normal stroke volume and the normal SVR. This is the weak pulse or pulsus parvus. That is low volume pulse. It either could be a low stroke volume or it could be due to a high SVR, where the blood vessel prevents the distension. So the pulse amplitude will be less. Then low dP by dt, that is it rises slowly. The stroke volume is delivered slowly, so that the absolute height will be less. So in the first instance, the stroke volume is delivered abruptly, whereas in the other instance, it is delivered over a time, so the volume will be less. Large bounding pulses, the reverse of that, high stroke volume, any high output stage, low SVR when there is a peripheral vasodilatation, and when the dP by dt is more than normal, then you can have a high volume pulse. As such may not, but in hypodermic circulations, it may be important. Or when you give dobutamine, the pulse becomes stronger, but the stroke volume may not be increasing to that extent. When you give dobutamine, you find that the pulse volume becomes very strong, but the cardiac output may not be increasing that much. Collapsing pulse. Collapsing pulse as a rapid upstroke, because the ventricular systolic function is strong, the systemic vascular resistance is low, the stroke volume is low, so that the rate of pressure rise is high. The volume ejected, stroke volume is ejected is high, the pulse volume is high. And all these conditions will have a low systemic vascular resistance. So if you look at AR, the stroke volume is high, the ventricle is distended when there is no heart failure, the ventricle is distended, Frank-Starling's law, strong contraction, rate of pressure rise is high. And in this situation, when there is AR, to reduce the AR, the peripheral resistance decreases so that the forward flow is maintained. This is a protective mechanism. In hypodermic circulations, in aortic runoff, the SVR comes down to draw the blood to the periphery or the tissues, thereby partly reducing the regurgitation. That is a natural mechanism by which the AR is compensated to some extent. So that is a rapid upstroke, ill-sustained peak because it runs off in systole itself because the peripheral resistance is low. Then rapid downstroke, and the diastolic notch will be at a very low level. So that is a classical thing. You should know this thing because it is always asked, and only seldom the student tell all the four things. It gets in hypodermic circulation and when there is aortic runoff. When you talk about aortic runoff, it could be to the left ventricle as in AR or truncal regurgitation. It could be to other chamber like right heart, RSOV, and coronary artery fistula, where it runs off to a chamber. Arterio-arterial, that is from the aorta to another artery, the classical is PDA, AP window, AP collateral deviation, where the blood flows from the aorta to the pulmonary artery. Then arteriovenous when it runs off into the veins. All these are aortic runoff where you can get the same phenomenon. But seldom you get the typical collapsing character other than severe AR. You may get a high volume pulse. In PDA you get. RSOV, if it is chronic, you get. But many times the RSOV is acute. In acute AR, you won't get. All these things are seen only in chronic situations. Bispherians pulse. A rapid upstroke, ill-sustained peak, then comes another thing. This again because in AR, the large volume is emptied. dP by dt is high, so the pressure rises very fast. And in systolic up, the runoff occurs, it drops. By that time, the reflectant forces come. So that the second wave, this wave becomes the percussion wave and the tidal wave. The tidal wave becomes well separated because the rapid ejection, aortic runoff to the periphery in systole, and then the recoiling comes and the tidal wave becomes prominent. Now, I have asked many times, can you draw the electrocardiogram? When does the systole S1, S2 occurs? Many people said that S2 occurs here. You should know Bispherian pulse both occurs in systole. And this is not because of the aortic runoff in diastole. That's very important. Only seldom the students answer that this is in systole. They say that it is because of the aortic regurgitation, the runoff from the aorta which is producing this thing. No. This is occurring, and in AR also, this diastolic drop, this drop in systole occurs. Don't say that this is a rapid downstroke is because of the aortic regurgitation runoff. No, it is in systole. In systole itself, after the rapid ejection, there is a rapid runoff to the periphery in systole. So the Bispherian pulse as well as the collapsing pulse, the downstroke is in systole, latter part of systole. Is it clear? Rapid upstroke, large volume, high dP by dt, it goes maximum ejected, then the blood flows from the central aorta to the periphery rapidly in systole itself, the reflectance occurs, and that produces, because this stored a high amount of kinetic energy, the reflectant burst will be very easily picked up. It starts at a lower level, whereas ordinarily it starts at this level, the original normal pulse. I hope it is clear to others, because there is no interaction. I can't understand whether they are following or not. Next thing is, these are the areas where you should have a clear concept. Then comes the pulsus parvus et tardus. The pulsus parvus et tardus. Parvus means low volume. It can occur in any condition where the stroke volume is low. But in aortic stenosis, the important is the tardive pulse, the slow rising pulse. That is the most important. Because of the obstruction, the left ventricle cannot empty the pulse very fast. Even though it can generate the pressure, the aortic valve doesn't permit the completion of the ejection. So the ejection is slow. So that you find that slow upstroke and the peak of the pulse is quite delayed because it takes a longer time. If you have the simultaneous LV tracing, you find that the aortic peak occurs much later than the LV systolic pressure peak. Okay, that is the low volume, but more important is the slow upstroke. Sorry, the top one is the normal, the low volume slow upstroke. This indicates severe valvular aortic stenosis. There is no doubt about that. There is severe valvular aortic stenosis. It becomes more prominent when there is LV dysfunction. So if you say that I have palpated endocrine pulse confidently, usually there will be LV dysfunction also, because it is not an easy finding. Many times in the examination, we cook up the data. You know the diagnosis, you cook up the findings, difficult findings. For example, one is pulse, second is JVP, and third is the second heart sound. These are the areas where you cook up based on the diagnosis. We are not interested in the diagnosis. Now, this is the next important thing in pulse. If there was somebody, I could have asked them what it is. That's why the pulse and BP, it is interactive. Now, you find that the pulse volume is changing. Not only the pulse volume, the most important is the pulse pressure. The pulse pressure is changing. That is, the stroke volume is coming down. You find that during inspiration it is coming down, and during expiration it is going up. This is the pulsus paradoxus. Okay. That is, during inspiration, it comes down, and during expiration, it goes up. That is pulsus paradoxus, an exaggeration of the normal response. Normally, there is a fall by 5 to 10 millimeters. This is exaggerated. Normal change cannot be palpated easily. Now the question comes, how will you confirm this thing? There are two things: total pulsus paradoxus, where it is easy, because during inspiration it almost disappears. Your documentation is by blood pressure. I have asked many students how you record this thing, because nobody has recorded it, because only occasionally you get it. Before that, by echocardiogram you have diagnosed cardiac tamponade. Now the question will be, what are the other conditions? Like COPD they answer. Then what is the difference? Okay, in COPD, the pulse pressure doesn't change much. The change is because of the marked fluctuation in the intrathoracic pressure. So the normal variation of 5 to 10 millimeters is mainly contributed by the negative intrathoracic pressure during inspiration, plus some hemodynamic change. So in COPD, that is the main thing, so that there will be a marked fluctuation, but the stroke volume doesn't change much, so that the pulse pressure doesn't change much. Whereas in cardiac tamponade, it is mainly because of the reduction in the stroke volume during inspiration, because of the ventricular interdependence and the mechanism. That is, during inspiration, more blood comes to the right ventricle, the left ventricle becomes small, and all those things. The mechanism you should learn. How to confirm it, how to record it. Okay, this I will put it like this. Let us say this is the systolic pressure. Okay, so during expiration, you can hear all these coraco sound. Tuck, 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 tuck. Then a long gap. Tuck, tuck, tuck. Gap. Tuck, tuck. So clustering of sounds. That is, regular sounds, 3 or 4 things, no sounds. Regular sounds, 3 or 4, no sounds. Don't ask the patient to hold the breathing, because this is a dynamic thing. And cardiac tamponade, they cannot hold. That's a different thing. But it is not related to holding the breath, because this is a dynamic thing. All dynamic maneuvers are during normal full breathing. It is not ask them hold the breath during inspiration, expire, hold the breath. No, it is normal full quiet breathing. You find that during inspiration you hear the coraco sounds, then it disappears, a gap, then again it clusters of regular sounds, then gap. That difference from where you start hearing the sounds, that is the systolic. That is the systolic, then it disappears. You may be able to bring it down. What you do is, you keep it around 110, you will hear these sounds. You bring it down, you will hear 2 or 3 sounds. And when you bring it to hear something like 80 millimeters, you will hear continuous sounds. So start deflating gradually, just like at 110, tick, 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 tick. At around 100, tick, 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 tick. And when it reaches 80, tick, 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 tick. So from that clustering, pauses to continuity, that is the difference in the pulses, pulsus paradoxus. What is the difference between these two? These two look same. That is like an alternance. Alternate pulses are strong and weak. But the difference is the rhythm. Pulsus alternance is in regular sinus rhythm, classically, or in any rhythm which is regular, without AV dissociation. So classically, we describe it in sinus rhythm. In regular rhythm, the pulse occurs regularly with alternating volume. That is pulsus alternance, which has great significance. Here, the alternate pulses are weak because of the bigeminal rhythm. This is coupled beats, long diastole, better stroke volume, short diastole, lesser stroke volume. So the bigeminal rhythm produces the pulsus bigemini. Pulsus bigemini is an abnormality of the rhythm and volume. Pulsus bigemini is an abnormality of the rhythm. The volume changes because of basic abnormality of the rhythm, whereas pulsus alternance is primarily an abnormality of the volume due to severe LV dysfunction. Now coming to the JVP, these are some of the things which I want to discuss about pulse. There are so many things, but time doesn't permit. But these are things which are usually asked in the examination. So coming to the JVP, you know that The JVP starts from here, that is between the two heads of the sternocleidomastoid, and goes up to the angle of the jaw. So it goes like this. So when to look how to differentiate between arterial and venous, the first thing is the anatomy. For JVP, definitely you have to look into the neck, not in the abdomen. For carotid also, you have to look in the neck. So anatomy is very important, surface anatomy. The JVP, the surface anatomy is from the point between the two heads of the sternomastoid to the angle of the mandible. Now you look, it is diagonal to the sternocleidomastoid. So in the lower third, it is behind the sternomastoid. In the middle third, it is underneath the sternomastoid. In the anterior third, it is in the upper third, it is anterior to the sternomastoid. So that is diagonal to the sternocleidomastoid, whereas carotid is throughout anterior to the sternocleidomastoid. That is the first thing. Then there are so many other things. You can see a definite upper level. It is better seen, the other is better felt. This is soft, the other is strong. Then definite upper level, which varies with respiration, which can be obliterated, which varies with posture. It can be obliterated. Then wavy, and the other is jerky. This is a question which is asked in the examination. I don't know whether you know all the 8 points. If somebody writes 8 points and show to their teacher, I am happy. Now you can see the JVP here. Can you see it? Dr. Girish? Dr. Girish, probably he may be.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Yes,
It's a nice thing.
Yeah.
Okay. Okay. You can see the external jugular plus the internal jugular. You can see that. The external jugular, the advantage is the dynamic nature or the waveform is better visible in the external jugular, but we have to concentrate on the internal jugular. You can see that it is lower down, it is here, here, and anterior. Whereas the external jugular goes diagonally to the clavicle. Okay. Now you can see the pulse. Now you can see that external jugular where the waveform is very prominent. What are the informations? I could have, if there was a postgraduate, I would have really enjoyed it. Okay. Now you can see there are so many things. One, you can see that, is it regular or irregular? It is irregular. Then you see that the descent is more impressive. That is a normal JVP. The Y descent is the most impressive. The most impressive is X descent. Sorry. X descent is the most impressive in a normal JVP. But the descents are more impressive than the ascents. Now here that you can beautifully see that descent is beautiful. It is irregular. You are seeing only one wave and there is a descent. So what is the diagnosis? Tricuspid regurgitation. Now this is the ACV. A, you know, it is the atrial contraction. A wave has to have an ascent and descent, then only it becomes a wave. So A wave has an ascent and descent of the A wave is the X, initial part of the X. It is passive. It has no influence. It has no additional informations. The atrium contracts and the contractions recedes, the wave comes down. So this part of the X descent has no significance at all. In atrial fibrillation, what happens is this will be absent, but you will get the C wave and the V wave. So when you are asked what happens in JVP in atrial fibrillation, they will say that there is only one wave. No. Unless there is severe TR, when the V wave start with the C wave, you will get, I can show you in the next slide or some other slide. Yes. You have normally A wave, C wave, V wave, Y descent, and then it rises. Okay. And then it plateaus. In diastole, there is a progressive filling of this thing and it plateaus to form a wave which is the H wave, which is usually seen when there is bradycardia. Then you have the A wave. So when you take away the A wave, you will have the HC, the X prime, and the V wave Y descent. So you will have two descents unless there is severe TR. Okay. So the A wave due to atrial contraction, the descent of the A wave due to atrial relaxation is the X part, the primer, the first part of the descent, and then you get the C wave during isometric contraction. The ventricular pressure rises, it pushes the tricuspid valve apparatus upwards so that there is a transient elevation of the right atrial pressure which produces the C wave. Okay, earlier it was thought that it could be carotid artifact, but it is unlikely because this occurs during the isometric contraction phase. Then people ask, what is the mechanism of the sharp X descent? Now somebody says it is the tricuspid where flow rises, then it comes down, then it should be only this much. What is the mechanism of this? If the students are interested, they can write down the answer and send it to one of us. Dr. Girish, you would like to put that exercise or would like to teach?
Sure,
them?
sir. Sure.
You don't.
I think they can put it in the chat box.
Their answer.
Yes, sir.
Without their identity.
Yeah. Without their identity, they can just give the answer to the technical team, which can
That
be
is the
shared on
X prime. X. This is the X. This is the X prime or the X dash. So you can write the explanation for the X prime or this part of the X and put it. Then what happens is this is occurring in systole. Okay, more blood comes to the right atrium or the atria. So if the volume increases, the pressure rises. So the V wave height is determined by the volume coming to the right atrium. So if there is a large volume coming to the right atrium, the V wave will be prominent. That is important. Because many people knows only TR as the answer for prominent V wave. Any situation where the right atrium is receiving a larger volume fairly fast, the filling will be more prominent and the V wave can be very prominent. And here at the end of systole, the tricuspid or mitral valve opens and the whole blood, the ventricle relaxes, the blood flows down to the ventricle in the early rapid filling phase. And this phase, this part corresponds to the ventricular diastolic part. This part corresponds to the ventricular diastolic part. I have not taken that tracing. That is, the tricuspid or the mitral valve opens. There is a rapid flow of blood from the atrium to the ventricle so that it comes down. Then the flow comes down and it rises. Towards the end of the diastole, the atrium contracts, gives rise to this wave. So this is the normal ventricular diastolic pattern also. Okay. So atrial contraction, atrial relaxation, X, which is part of the A wave, not at all important. C is isometric contraction so that the pressure rises. Then you have the X prime or the X dash. As the ventricle ejects the blood to the pulmonary circuit or the aortic circuit, the elevated tricuspid flow comes down. Fine. Then why should it come down further? It's a difficult answer. The same thing from the onset of the C wave to the end, the peak of the B wave is systole and the rest is diastole. Now, the first question in JVP, is it visible or not visible? If it is not visible, you don't know how to examine the JVP. I'm sure that I have been training students, even now I am training students bedside. Many people are not looking, forget about them. Consultants are also not looking because now you go by indirect methods, but in examination it is very important. If it is not visible, you have not examined properly. Okay. Then you say, I have examined. In which position? Sitting position. That is a standard now. If it is not visible, put it in 45-degree position. If it is not visible, put it in supine position. If it is not visible, then the commonest is hypovolemia. Well, their RA pressure is very low. So hypovolemia is the commonest condition where you are not able to see the JVP even in a head-low position. Then when it is above the ear lobule, you may miss it. Okay, but you can pick it up. If you are not seeing on the right side, don't forget one thing. Look on the left side. If there is a left SVC, the right SVC is small and the pressure may not be easily visible. This, you will be in trouble in the examination. Because if there is a left SVC seen, that will be kept and you will miss it. Because this is my experience. So if it is not seen on the right side, examine on the left side. If it is not seen, examine. You are competent. Yes, sir, examine. It is not seen. Then see whether it is hypovolemia or if it is elevated above the angle of the ear lobule, angle of mandible. You may not see because we are definitely seeing the upper limit which is going and coming down. Then what you can do is keep the hand like this. Okay. You can see now you can use yourself, put the hand down. You can see the veins on the dorsum of the hand. You gradually raise it, When it comes up to the level of the shoulder, you can see that it is becoming flat normally. And you raise it, normally it collapses. Keep it for some time. Whereas if it is still, erase it. If it is still visible, that means the jugular venous pressure is elevated. Either it is markedly elevated or there is SVC obstruction. If this is elevated and non-pulsatile, obviously SVC obstruction should be considered, but this is classically seen following a Glenn procedure where the SVC is connected to the pulmonary artery. So it is not connected to the right atrium. So the right atrial events are not seen. You will see only the pulmonary artery events. And because in these situations, the ventricle is not ejecting blood into the pulmonary circuit, the wave will not be very impressive. But the DM question or DNB exam question, if I put a catheter into the jugular venous pressure, you will get a waveform. What is the like? I have pulmonary atresia. Okay. A Glenn procedure was done as a palliative procedure. Okay. And catheterization was done, putting the catheter in the SVC, and you get a waveform. What is that waveform? Put the answer in the chat box. Whoever is writing the answer in the chat box will get some compliments from the organizers. Okay. It should be a verbal compliment, which is the most rewarding thing than a toffee or something else. So in the JVP, you look for the height. Now the standard reference point examination, it is sitting up with legs down, the clothes loosened, and looking in the sitting position from the root of the clavicle. The head should be straight, neutral, not turning. It is not turning like this or that. It should be neutral. And look from behind. Look from behind. You can use apply light by torch, hand torch, or with your mobile. Waveform. As we have said, you look whether C wave is not visible, because in one of the examination, I have said, I have seen a student answering, sir, I can see 3 waves. He can see AC3, and he said, I can see the 2 parts of the X descent. Dr. Grish, what should we do with him if that is the situation? He said that he can see 3 waves, and he can see the 2 components of the X descent and the Y descent. Okay, too much or 3 much? Okay. I heard that one student telling that. And the internal examiner said he is a good student. Okay, fine. The internal examiner supported him. Okay. The waveform we said, you can see the descents more impressive. Respiratory variation seldom you look for. Quiet breathing, not deep breath. Quiet breathing, you can see normally it falls. The pressure falls, but the waveform become more striking. So the wave becomes more striking, but the wave height comes down. The wave becomes more striking because during inspiration, more blood comes to the right atrium. The right atrium stretches so that the atrial contraction becomes stronger. So that during inspiration, normally the pressure drops, but the wave becomes more prominent, impressive. You got it? Normally, the negative intrathoracic pressure transmitted to the right atrium. The right atrial pressure falls so that the JVP falls. That is a mechanism of the normal inspiratory fall. Because more venous return is coming, but the negative intrathoracic pressure is transmitted to the heart, so that the right atrial pressure drops, so that the venous column drops, even though there is an increase in the venous return. More blood comes to the right atrium stretches, stalling force, so that the contraction becomes stronger, they may become more impressive. The respiratory variation, abdomino-jugular reflex, it is jugular reflex. That is in 45-degree position, quiet breathing. Press the abdomen, not the liver. Even though it was initially hepatojugular, you are pressing the abdomen, raising the intrathoracic, intra-abdominal pressure, squeezing the planktonic venous return, large volume, suddenly to the right atrium. A normal right ventricle can accommodate this. Whereas a failing right ventricle cannot accommodate this large volume so that the venous column rises. That also happens when there is a tricuspid obstruction. Okay, because the large volume cannot flow to the right ventricle. Okay, now how it is done? This is the question which is asked. A rise in pressure by more than 3 millimeters, and it should be sustained for 10 to 15 seconds. The time factor variable, but in general it is 10 to 15 seconds compression, and it rises by 3 millimeters. Or on releasing, it falls by more than 4 millimeters. That is abdominal jugular reflex. Okay, it positive or it sustained elevation in right ventricular dysfunction. Second, tricuspid obstruction. Okay, and in left heart failure, this correlates with the pulmonary capillary wedge pressure also. We are not bothered about that. The important question is What are the situations where abdominal jugular reflex is absent? You compress, okay, it is not going up. What are the situations? Write down the answer also. Put it in the chat box. So now we have 3 questions. I think Girish, our technical support team, or somebody can write down these 3 exercises. I may forget that because I can take it then and teach them. I have put 3 questions. One is abdominal jugular reflexes absent. The next one was this Glenn procedure. What will be the waveform if you put the catheter in the superior vena cava, and the mechanism of the X prime in JVP. Note down because I may forget this.
Yes, sir. Sure, sir.
So you can see that during inspiration, you find that the venous column is, you look here, the venous column is becoming more prominent. That is the normal expression is coming up. Normally it comes down, and this is Kusumal sign, which I have shown, where during inspiration it is going up. You can see that during inspiration it is going up. Can you see that, Dr. Girish? Is it visible?
Yeah, it's visible, sir.
That is during inspiration it is going up. That is Kusumal sign, opposite of normal. Then prominent wave, usual questions. What does it indicate? It indicates that there is atrial depolarization, electrical. Second, there is a responsive atrial myocardium. There again a question comes where there is atrial depolarization, but the atrium is not contracting. There is a 4th question. Electrically, there is P wave, but if you do Doppler, there is no atrial flow to the ventricle, or there is no A wave in the right atrium. What is the condition? So A wave indicate that there is electrical activity of the atrium. There is a P wave. Second, atrial myocardium is normally it is responding to the atrial activation. That is electromechanical association is there. Second, there is a resistance to atrial emptying. Atrium is contracting, but it cannot empty and intact intra-atrial septum. Because if there is an ASD, even if there is tricuspid stenosis, when the atrium contracts, it can empty to the left atrium, to the left ventricle. So these are the 4 the basic things when you find an AV prominent. There is an atrial depolarization AV, PV. The atrial myocardium is okay. There is a resistance to atrial filling, and the intra-atrial septum is intact. There is no non-restrictive ASD. Large ASD is not there. Okay. So you can see that. Can you see that prominent wave? How do you differentiate between an A wave and a V wave? A wave is a pre-systolic wave, so it occurs before the carotid. V wave is a systolic wave, so it occurs with the carotid. That is the most important thing. Second, the appearance. A wave is a sharp wave because it is an active wave. It is a contraction wave. Whereas V wave is a passive filling wave, so it's a slow wave. So now the question comes, what is a Cannon wave? That is a 4th question. What is a Cannon wave? Or this is the 5th question. Anyway, Girish and Gupta maybe, Sumod may be noting down the questions. I can take it down later. We can answer that later. So what is a Cannon wave in the JVP? When we will say this is a Cannon wave? Prominent wave, resistance to atrial emptying offered by the ventricle as in RVH, pulmonary stenosis, pulmonary hypertension, hypertrophy due to any other cause, or any RV myocardial disease. For example, acute myocardial infarction, RV is non-compliant atrium may give a strong contraction. Or RV inflow obstruction like tricuspid stenosis, acyanotic, cyanotic tricuspid atresia, seldom in Epstein's anomaly. I don't know what should be the answer in ASD with MS. Some people may say A wave can occur, but I may not agree because atrium can empty easily to the right heart. I think we'll get the answer from Girish, Dr. Girish and Dr. Sumod. Can you contribute?
Sure, sir.
A wave in ASD with MS. What will be your teaching? Is it impressive or unimpressive?
Sir, it can be impressive only in presence of sinus rhythm.
Yeah, in sinus rhythm, because what we have been taught, or what I have my concept is, this is a common atrium and the right ventricle is very compliant. So whether there is a tricuspid stenosis, the right ventricle and right atrium can empty to the right ventricle freely. So why should there be a prominent AV? So you debate on that in the department and convey to your PGs what is the answer expected from them during examination. Okay, this I have discussed earlier. Now this is the JVP. Here again you can see both the internal jugular, but the external jugular is better seen. As shown earlier, there is a single wave and a prominent Y descent. VA become prominent, as I've said earlier, when it is receiving a large volume or a large pressure during systolic. Okay, a large volume or a large pressure are combined. In TR, the RV systolic pressure along with the volume is empty to the right atrium. So there is a commonest condition where you get prominent VV. This could be from the right ventricle as in simple TR, or from left ventricle to the right atrium as in LVRA shunt, or left ventricle, left atrium through atrial septal effect into the jugular vein. So these are the conditions where you get the transmission of the ventricular volume and pressure to the right atrium. Simple TR, LVRA shunt, ASD with MR. Or the right atrium is receiving a large volume under high pressure, or is in RSOV, coronary artery fistula, or any other arteriovenous fistulas. Now coming to the descents, X prime, the initial part will be absent when there is atrial fibrillation or when there is no atrial activity. Okay, when there is no atrial activity, when there is no P wave, you may not say sinus arrest, you may not get AV. In atrial fibrillation, you may not get AV. And the third situation is where you get sinus rhythm, but AV is not seen because atrium is non-responsive. The X descent, normally the X descent is sharper than the Y descent. And this V is above the CV. So in normally right atrium, A is more prominent than the VV. In left atrium, V is more prominent than the AV. This is a standard question in the examination. Why in the left atrium V is prominent? Because the left atrium is relatively small. It cannot distend because it doesn't have much space. It is a posterior structure bounded by the large heart anteriorly, aorta behind, so and the spine. So it cannot distend. Compliance is less. The right atrium is a free chamber. It can distend freely. So here the compliance is less because of that. Not only that, the pulmonary vein, the closer to its ostium, there are smooth muscles. SVCU doesn't have smooth muscle. That smooth muscle extends to the left atrium so that there is a resistance to the left atrial expansion is more, or the iliac compliance is more, so that the same volume comes to the right atrium, left atrium. You know that the RV output is same as the LV output. The volume coming to the right atrium is same as the volume coming to the left atrium normally. Okay, so for the same volume, because the iliac compliance is less, the LA pressure for the same volume or the V wave will be more prominent. Now, A is more prominent than the V, X is sharper than the V. That is important. Whereas in constrict pericarditis, I don't have that. Okay, in constrict pericarditis, you have the A and B equals. In a large ASD also, it is a common chamber, common behavior. So A and B becomes equal. Now that I am not putting too many questions, what is the difference between these two? A and B will be equal. In constrict pericarditis, JVP is grossly elevated. In ASD, usually it is not elevated. When it is grossly elevated, it is in the elderly with heart failure, where they usually will be in atrial fibrillation. But the more important thing is the descents are normal in atrial septal defect, whereas the X descent is sharp, the Y descent becomes sharper. So it has the classical M pattern in constrict pericarditis, whereas the descents are normal. So in constrict pericarditis, the most important is A equals V with a sharp Y descent. The X and Y will be same. So it produces the classical M pattern. Whereas in ASD, the only thing is A is equal to VV. The descents are normal. Is it clear, Dr. Girish?
Yes, sir.
Okay. Now, Y descent, as the tricuspid opens, blood flows freely from RA to RV. Sorry, not TV, to RV. So that the pressure drops suddenly. The slow Y descent indicate that there is a slowness in the emptying of the right atrium. That means obstruction to this flow, classically TS. So tricuspid stenosis diagnosis is mainly by the slow Y descent, plus all the other findings. Sharp Y descent, severe TR without TS. Because there is a large volume, RA pressure is high. When the tricuspid valve opens, this large volume flows down. So you get the sharp Y descent. Then constrict pericarditis. In severe TR, the V is very prominent, much taller than the AV. Whereas in conjunctive pericarditis, A equals V. This is the difference between conjunctive pericarditis and atrial septal defect. It is called M pattern or W pattern. TR, prominent VV. I didn't get a diagram. Now, okay. This is the X descent, the isometric contraction, and this is part of the systolic. Okay. So the V wave starts here. As the TR starts, the regurgitation starts earlier. So the V starts here, V starts here. As the severity increases, it starts here. And in a severe case, with the isometric contraction itself, the whole blood or a large volume regurgitates, so that this V wave, as the severity increases, encroaches to the X descent proximally. And what happens is the X descent gets partially obliterated, and severe TR, it gets completely obliterated, X prime, so that it is the C with the V wave, which we call as the CVV. So this is the A wave, CVV. Okay. So you will not get the real X descent. I have discussed conjunctive pericarditis, ASD, tricuspid stenosis. Notice I think this is the last slide for teaching. Okay. Importance of JVP in rhythm problem. Okay. The pulse and the JVP. Sinus rhythm. Pulse rate is normal. It is regular. It is normal. So you have a rate, a rhythm which is regular, a rhythm which is irregular. We take it as AF unless put otherwise. Ectopics I am not discussing because it is easy. Tick, 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 tick. If it is an irregular pulse, especially tachycardia, coming here, tachycardia, irregular is AF. If it is regular, JVP is normal. You can see the normal A and V, it is sinus tachycardia. If you can see regular cannon waves, it is SVT. If you can see irregular cannon waves, it is VT. In a slow rhythm, if there is a normal JVP, it is sinus bradycardia. If there are irregular cannon waves, it is complete heart block. If there are regular cannon waves, it is a slow junctional rhythm. So in a rhythm, if the JVP is normal A and V, it is sinus. If you are seeing regular rhythm, it is a junctional rhythm. I will not say junctional rhythm, something like that, because now we differ in that. Junctional rhythm or whatever it is, there is a narrow QRS with a P wave immediately after that. The rate is fast, it is junctional tachycardia or SVT. The rate is slow, slow junctional rhythm. An irregular JV, a regular rhythm, irregular cannon waves. In a tachycardia, it is VT. In a bradycardia, it is complete heart block. Okay, that's about the rhythm problem. This is all what I have to teach. Then I thought I will take some exercises like this. A 12-year-old boy complains of palpitation and exertional dyspnea. On examination, amidst systolic murmur. What is the question is, what is the JVP like? So obviously a 12-year-old boy with mid-systolic murmur in left channel border, acyanotic, it should be ASD. So you have to say JVP is normal, it is not elevated, A and B equals X and Y normal. X and Y normal. A equals VV. Case 2, newborn, 3-day cyanosis, single S2 and a long systolic murmur along the lower sternal edge. Okay, if it is tetralogy of Fallot, very unlikely to have cyanosis on day 1. If it is tricuspid atresia, you get prominent A waves. So prominent A wave in a cyanotic, first thing you suspect is tricuspid atresia. A 3-year-old boy, central cyanosis, normal S2, systolic murmur. Normal S2 in a cyanotic, it is, what is that? Pulmonary AV fistula. For practical purposes, almost always the second sound will be abnormal in a cyanotic heart disease. So a normal second sound in, if you are sure it is normal, in a cyanotic, it is likely to be pulmonary AVF. 14-year-old girl, cardiac murmur by second month, exertional dyspnea and palpitation now. There are two possibilities. One is they are developing Eisenmenger syndrome, or the VSD develop cardiac murmur by second month. Commonest is VSD. And by 14 years, they develop Eisenmenger syndrome. What will be the JVP like? JVP usually unimpressive at 14 years. You won't get prominent A wave in Eisenmenger. Maybe that is a debatable thing. A prominent AV wave may occur in ASD, debatable thing. Okay, fine. Now there is some quiz. So I hope I have covered certain things. It is almost 1 hour. So if you have got some answers for the questions, I will discuss.
Yes, sir. We do have some answers, sir.
Yes.
On the
So
chat
we'll take
box.
the first question.
Yes, sir.
First question was,
Mechanism of X prime.
I will give the answer so we can see whether they are right or
not.
wrong.
Yeah, that's
Okay.
right.
What happens is, let us say the cardiac volume, the atrium fills. So here the systole starts. At that point, let us say what is the volume of blood in the 4 chambers, total volume. Let us say it is 200 ml. Okay. Let us say it is 200 ml in 4 chambers. During isometric contraction, nothing happens. Maybe some flow is coming to the right atrium. But during ejection, what is happening? During ejection, the 2 ventricles have emptied something like 140 ml to the aorta. So what is happening to the cardiac volume now? Coming down. What is happening to the intraperitoneal pressure now? Coming down. So that sucks the blood to the right atrium. So the ventricle is emptying. And it is emptying, right ventricle is emptying, left ventricle is emptying, something like 140 ml of blood or 120 ml of blood. So that much of blood can be drawn to the right atrium. The right atrial pressure drops. That is because of the acute reduction in the intracardiac pressure. The pericardial pressure is determined by the pericardial volume, the cardiac volume. So during ejection, the cardiac volume comes down. So that the intraperitoneal pressure drops and it sucks. When intraperitoneal pressure drops, the atrial pressure also drops. Normally, the intraperitoneal pressure and atrial pressures are almost the same. Okay. So during systole, the ventricle is ejecting blood to the extrapericardial space, aorta and great arteries, so that the cardiac volume is coming down, the intraperitoneal pressure drops, and hence the right atrial pressure drops. That causes the X descent. Okay. What is the next question?
The next one was Sir Glenn shunt.
Glenn shunt. What will be the waveform if it is functioning properly? Anybody has written it is the pulmonary arterial wedge tracing?
No one, sir.
Because now the blood is flowing from the right atrium, superior vena cava, to the low pressure pulmonary artery, through the pulmonary capillaries to the left atrium. So it is likely to reflect the left atrial pressure. Not easy, but you may record a very mild waveform. Okay, especially if you go distally. What was the next question?
Absence of hepatojugular reflex.
Absence of hepatojugular reflex. Anybody has written?
Yes, sir. A lot of people have written about absence of abdominal jugular reflex. One has IVC thrombosis, Budd-Chiari's.
Okay, IVC obstruction, SVC obstruction. Fine, great. IVC obstruction, it cannot rise.
Yeah.
SVC obstruction, it is not reflected.
Yes.
Because the vena cava is not connected to the right atrium. Very good. Excellent. Then the other one?
The other one was
A wave.
A wave is absent, but P wave is seen on electrical.
P wave is seen, but no A wave, and you do mitral Doppler. Okay, A wave is, there is a P wave, but there is no atrial responsiveness. What is that condition?
Amyloidosis.
Amyloidosis, oh, okay, it can.
That's one of the
hyperkalemia, severe hyperkalemia. That should be the first answer. That is electromechanical dissociation, producing what is called a synovial. That is, atrium may not respond at all electrically, as well as this thing. Earliest thing is it doesn't respond. Later, you may not get a P wave even. So initial part, it doesn't
Can this
respond.
be a finding in acute conversion of sinus rhythm
following atrial fibrillation?
From a atrial fibrillation.
So that is what is, yeah, that's right. Chronic atrial fibrillation, when you convert to sinus rhythm, you will not get the atrial contraction, atrial paralysis.
Yes.
Atrial paralysis can occur in hyperkalemia, amyloidosis it is described, and as rightly said, following conversion of long-standing atrial fibrillation especially to sinus rhythm, initial cycles, the electrical activity may come, but the A wave, the mechanical activity will be delayed a little later. Very good. Then
and
that's
last one was Cannon wave, sir. Definition of Cannon wave.
Not definition. JVP, when will you say what you are seeing is a Cannon wave?
Yeah.
Anybody has written that?
They've not given the.
Okay. A wave, Cannon wave is an atrial contraction wave during ventricular systole. So it should be an atrial wave, so it should be a sharp wave. V wave is a slow wave. So it's a flickering wave, which normally occurs before the pulse. This should occur with the pulse. So if you get a flickering wave with the pulse, that is Cannon wave. Okay. Now,
But I think there is a definition also, sir. Probably, I think raised by 5 centimeters.
that is the absolute height. That is there's a
Absolute
problem. There is
Yes.
a giant A wave versus a Cannon wave.
Cannon.
The giant wave is more than 5 centimeters. Cannon wave has to have a prominent A wave. It is timing is important, Cannon wave.
Yes.
So it should be an A wave occurring during ventricular systole, because V wave can occur during ventricular systole. So it should be the character of the A wave. It is taller, but the timing is important. Cannon wave. The other is the giant A wave, where it is a pre-systolic wave, which is very tall, giant A wave. Okay. Now, if
This
you have time,
Giant A wave is as similar to that of what we call it a Venus corrigans, or is it different, sir?
Venus corrigan, I think, is the CV wave. I'm not sure. Venus corrigan. I thought it was the CV wave. I'm not sure. You check that and convey to the students.
Yes, sir. Sure, sure.
Okay. Now, if there is a time, I can put 3 or 4 JVP, because, okay, I think 5 minutes can we have?
Go ahead, sir. Go ahead.
This is a very useful JVP for the students. Ask the students to write down the findings. 2 minutes.
Technical staff, please.
What is the diagnosis from the JVP? Full diagnosis for your examination. Anybody has written?
Not yet, sir. One comment is frog sign in SVT.
SVT, no.
It doesn't look like.
Okay, doesn't look like that. Okay, fine. The others I have not written. At least we give a compliment the person who has written the answer, because he had that guts to write. So he is the student of the day. Even though we may not fully agree with his answer, he gets a bonus mark because he has attempted. The others are quite passive, and I like students who are active. Then only grading comes. Okay, so I'm happy with that student who has attempted. Now I put it like this: JVP is grossly elevated, so he has CHF. Is the rhythm regular or irregular? It is irregular. Second, how many waves you are seeing? It is a single wave. Is it a sharp wave or a slow wave? It is a slow wave. What about that descent? It is sharp. So this patient has congestive heart failure, atrial fibrillation, severe tricuspid regurgitation, and no tricuspid stenosis, because the Y descent is sharp.
Yeah.
I mean, you agree, Dr. Grish?
Yes, sir.
Sumodh is there, or he's very passive today? Okay.
Yes, sir. Yes, sir. Yes.
Okay. What will be the JVP in this case? Write down. Anybody has written?
Yes, I think it's written at a CCP. Okay, sir. The one girl has written about the CV complex in the last case, in the last JVP.
What is this? What it is? Last one.
Yeah,
Okay.
CV.
But I want a diagnosis. I said diagnosis. Full diagnosis: congestive heart failure, atrial fibrillation, severe TR, no TS.
I think
These are the
other
information.
student has written about CCP in that case.
CV wave.
No. Another student who attempted that, sir.
This one or the previous
No,
one?
the previous one.
Okay, forget about that. Whatever answer wrong, I don't mind.
Yes.
But attempting itself gets the first person get that is rank 1. The other person gets rank 2. The other person gets rank 3 for attempting. The others are
comments for regarding this, sir.
regarding this.
No comment yet.
No comments. I am disappointed.
No, I think there's a delay in the answers coming. So yeah, that's the reason.
Okay.
So they are replying.
So you are a good internal. Very good. No, I think it has been there for the last 2 minutes.
I think you got the answer here.
Yeah. JVP finding.
She has written it as prominent A wave, absent Y wave.
Absent Y wave. Absent V wave.
They told tricuspid atresia, and because of that, prominent A wave.
Okay, fine, good. That gets a double bonus. Okay. Okay. Should be very clear now. What will be the JVP finding in this case? This is TR, severe TR, normotensive TR or normal pressure TR. This is the 3-dimensional picture. TR you can see. TR. Let us see what is the diagnosis from the echo, then they can write the JVP finding. If they got the diagnosis fine, then they should be able to see what is the JVP finding.
We're still getting answers for the previous echo finding.
Because there's a delay in transmission.
All of them get bonus marks.
But the involvement is good, sir. I got
fine.
Good number of responses.
So large number of bonus marks. So that means students are really interested. So only thing we have to stimulate them. So what we'll do is we go to the next. And let us see, because there is a delay. This is a exam case, echo. Okay, that is enough. What is the JVP finding in this case? So we'll give 3 or 4 minutes.
So diagnosis in both cases had come up in the screen, so I think people would have already diagnosed.
Clearly visible?
Yeah, it's clearly visible. Diagnoses are clearly visible. The previous case also in between came, so that should make it.
Okay, yeah. There is our tendency to look into the tip rather than going to the exercise.
Yes.
I've not seen that. Diagnosis, whatever is in my computer, it is not very clear. Okay. Professor Sumod, reminded of our postgraduate days.
Yes, sir.
We'll be after the tip rather than after the case. Okay. So we are just like you people, students. We also got the tip. For DM, I got the tip. DM, cardiology, the case which I got was the case which I took class for my juniors 2 weeks prior. I got a congenital heart disease in the OP. And at that time also I was interested in teaching. And I took an extensive class for them. I got that, but with Professor Tandon and all those things, it was difficult in the examination.
So for the first question, you got an
answer. Let me see whether I have this also. This is the last one.
Yeah, first one they told Epstein with no normal JVP.
Okay, we'll discuss that. Epstein with normal JVP, you should not write. because there is severe TR. So there some discussion comes. Because there was severe TR, so expect a prominent VV, but it may not be seen. Why? Because of the huge right atrium which they have. The TR is accepted by the right atrium, so the pressure may not come or it may not regurgitate to the JVP, jugular vein. So there was severe TR in that case. So you have to say that expect a V wave, but if the RA is markedly dilated, the TR will be accommodated by the right atrium. So the regurgitation from the right ventricle will be confined to the huge right atrium. It may not reflect to the vena cava. So you may not get the VV, but you can write VV may be prominent or VV prominent. Then the question comes, is it always? So that depends on the size and the compliance of the right atrium. If the right atrium is huge, it may not produce a prominent VV. That is the answer which I want.
I think Sumud, the next answer was ASD with prominent V wave.
That where the diagnosis was there.
Yes, sir.
So he is a good student because he has not gone to the diagnosis. Only our teacher has gone through that. They may be criticizing. The teachers have gone to that tip. We are very straightforward. We don't go to that tip. Okay.
Yeah.
Okay. I think he is so straightforward. He has not gone to the tip. Okay. There was an ASD. That's right. Not sure, because ASD diagnosis should not be made from a four-chamber alone,
Yeah.
because many times you may get spurious dropout. But then we may not agree with ASD because the right atrium and right ventricle was not large in that case. It was there. But the most striking was, anybody has written the correct anatomical diagnosis?
No.
Not really, sir.
No, sir. Yeah.
We have given enough time?
Yes.
Yes, sir. Yes, sir.
Then we'll go back.
Yeah. I think that.
The previous one, am I right?
Yeah, I think Epstein they already told. Epstein also was written here, diagnosis, but anyway.
This one.
This one they didn't write. They have not written.
Yeah, I think this again nice. Even the ECG is very good. I think AV dissociation plus both are there.
They might not have gone to the ECG. Now, basically, the students, what you have to do is, this is the atrium which receives the pulmonary veins. So this is the left atrium. Now you look that this valve or this left AV valve is closer to the apex. So this is the tricuspid valve. So left atrium to right ventricle, ventricular discordance, corrected transfusion. What is the cardiac arrhythmia in corrected transfusion? It is AV block, complete heart block. So you get irregular cannon waves. Okay. Now this is the last note for the consultants. The ECG should be looked into to see what is the timing. The systole starts with the peak of the RV. So here the systole starts. So you should analyze the wave based on the cardiac cycle. And the T wave is not well seen, but you can see that this is the QRS, ST segment, TV. Anyway, if the heart, at least half of it should be systole and half of it should be diastole. So the systole starts here, diastole somewhere here. Like that, you should, whenever you get a pressure tracing, you should first see which is systole and diastole. Then only you analyze. So this time, many of us have gone wrong because this is the systolic wave and this is the diastolic wave. So this will take as the V wave and this we may take as the A wave. But the A wave should occur only after the P wave. The wave should occur after the P wave. Now you see a wave which is occurring after the P wave and after the QR. So it is quite confusing. But the most important thing is you look at the pressures. The pressure here is 100 millimeters. So it is, now don't tell that, let me see whether they can. This is an arterial tracing. This is an arterial tracing. Now you can write the answer. Arterial tracing. Yes, they might answer that. But I have seen many students writing as constrictive pericarditis because it has an M pattern.
Yeah.
It has an M pattern. So when it goes like that, you give a wave M pattern constrictive pericarditis without looking into the values. In a pressure data, hemodynamic data, rhythm is very important. the shape of the waves, the value is very important. This is a hyper, you cannot have 100 millimeters of mercury in the veins. Anybody has written that?
I think they mistook for prominent X-ray.
Now we have given that.
Prominent X-ray, yeah.
Now they can, that candidate can try again. This is an aortic tracing, arterial tracing. He should be excused because many of us have made mistake this. When it comes to JVP, all those things we'll take it as M-wave and consider pericarditis. Okay. So ignore that, my friend. Now this is an arterial tracing. We have given a clue that you should look into systole and diastole. You have to analyze the waves as systolic, diastolic, and see what it is. We'll give 2 minutes and see whether that clue is effective or not.
Again, we're still getting on JVP, sir.
Not JVP, this is arterial tracing.
No, the responses are still on JVP, sir.
So they have not got the clue that this is arterial?
Yeah. I think they might have got, sir, but I think they might be.
They may be anxious. Why should they be anxious? Because we are not seeing them. Their identity is not revealed. And we are only complimenting them, not demoralizing them.
It is revealed, sir. Their name is being revealed here.
That is only by you people. You don't know from where they are.
Yeah.
Okay. Only if it is Sudhay Kumar, you know that there is only one Sudhay Kumar in the world. There are so many Sumod, so many Girish. Okay. So the name doesn't help us. Anybody attempted?
No, sir, not yet.
Okay. Now you find that this is the systole and this is diastolic. What is the situation where the diastolic pressure in the aorta is higher than the systolic pressure? It is iatrogenic. I cannot give a better clue. Okay. That is, we are supporting the hemodynamics during enhancing diastolic flow. There is the balloon counterpulsation in diastole, diastolic augmentation, intra-aortic balloon counterpulsation, or any type of diastolic augmentation. The classical is IABP. Okay. I think we had enough session. Brain teasing. Is it okay?
Yes, sir. Absolutely wonderful.
Excellent as always, sir.
So,
only thing is ASD with MS. What should be the A wave? Dr. Sumod and Grish, you sort it out in your department and tell the student that this is what we expect. I will not object to that.
Sure, sir.
Because I am also not sure. Some examiners want it as prominent A wave. Some others who are interested more in that this thing that RV is compliant. So why should it should contract strongly? It can empty easily into the this thing. Why in ASD there is no prominent A wave? All those things. Why it should be equal? All those things. You sort it out and convey to the student. And when the student come for exam, you should support them if they tell the answer which you are telling. Is it okay? Shall we call it a day?
Sure.
Yes, sir. Thank you
so much. Thank you so much for the company.
I think this was one of the best classes ever in my lifetime that I have listened to with such a beautiful, analysis of a very simple thing like that of pulse and JVP, with a very clear, mechanism of the different wave patterns, and some amount of physics to begin with in the mechanism of the arterial pulse. And I think I was fortunate enough to be a part of this class, sir. And I congratulate you on being such a wonderful teacher. I think you should be taking more classes so that more and more of us as well as the students are benefited and enriched by your knowledge, sir. And I thank you. I thank Dr. Sumod also who has been a wonderful part till now and who's been conducting these classes so very well. And on behalf of Mohit and Delhi CSI, CSI of Delhi chapter, and I would also like to thank the INTAS team for providing us the technical know-how of conducting this teaching program. And we would be meeting next Thursday at the same time. Thank you, sir.
Thank you. Thank you so much.
Thank you, sir. Thank you so much, sir.